Good evening, Tonche, bonjour. My name is Dr. Alika Lafontaine. I will be your facilitator for this evening, and I'm joining you from Treaty Territory and homeland of the Métis in northern Alberta. Given the virtual nature of this gathering, I would encourage you to take a moment to reflect on the lands that you are joining from, acknowledging the Indigenous peoples who have been the keepers and caretakers of this land since time immemorial. I served as president of the CMA in 2022-2023, and I will say that, like most CMA presidents, it was a life-changing experience where I had the opportunity to influence healthcare for the better. I'm really excited to be here joining you to facilitate this session and to hear from someone who will be the next president-elect coming from this region of Canada. I'd like to mention a few housekeeping items. For our French-speaking attendees, simultaneous interpretation is available by clicking on the interpretation button. That's located in the meeting control panel at the bottom of your screen. Select the language you would like to hear, FR for French or EN for English. If you do not select an option, you will hear comments in the languages spoken. As a reminder to everyone joining us, this session is being recorded. Welcome to the Meet the Candidate session for our upcoming CMA President-elect election. Every year, the President of the CMA is elected by members from a different province or territory based on an alphabetical rotation. This fall, it's Newfoundland and Labrador's turn to elect the President for 2026-2027. Only CMA members in Newfoundland and Labrador, where membership was active as of November 8th, are eligible to vote for the CMA President-elect between November 20th to December 4th, 2024. The results of the election will be announced by December 6th on cma.ca. The elected nominee will be presented for General Council approval at the AGM on Saturday, May 31st, 2025. For tonight's session, we have opened the attendance to all CMA members across the country. This session is an opportunity for members to hear candidates talk about their plan to be the national voice for physicians and support the CMA's work, the priorities that they're focused on as far as system change, and other key issues that are affecting the profession, especially in Newfoundland and Labrador. Candidates will begin by introducing themselves. Next, they will be invited to answer a question that we have received in advance. Then we will open it up for them to answer member questions. We've opened the Q&A button. At any time, please type in your question and click on Submit. I'll remind participants, as has been announced in the chat, that chat is not active for folks who are attending. So please use the Q&A button in order to submit your questions. We will vary the order in which candidates will answer the questions, giving each candidate the opportunity to answer in order. Each candidate will have roughly the same amount of time to answer. Dr. Susan McDonald and Dr. Olu Oganyemi, each candidate added to please introduce yourselves. We'll start off with Dr. Susan McDonald.
Good evening, everyone. I'm Susan McDonald. I started working in healthcare as a cleaner, a receptionist, a nurse, before going to medical school and a residency in family medicine. I've had a focused practice in palliative care for 30 years. I'm running for CMA President-elect because I believe in us. Medicine is still a great profession. I'm passionate about caring for my patients. I'm passionate for teaching, both at the undergrad, residency, and CMA levels. I've been on faculty at Memorial University for 26 years in a variety of positions, including acting dean, assistant dean of admissions. I have a long history of volunteering on various boards, both provincially and nationally. Some of my leadership positions have included 15 years as divisional chief, president of the NLMA just over 2 years ago, and president of the Canadian Society of Palliative Care Physicians in the year before MAID became legal. I believe that we're at a crossroads in healthcare. There's no option to stand still. There's lots of directions we could go, but I like the CMA's Impact 2040 plan because it focuses on health, healthy systems, and healthy physicians. There's a real chance that working with this plan, being strategic, being at the table where decisions about healthcare are made, focusing on aging and populations that have been long overlooked, as well as things like climate change and pan-Canadian licensure, as well as among others, are all very positive initiatives and powerful and effective. As physicians, we can make a positive change by working closely with our allied health professional partners, government leaders, and industry. We can use our creativity and our willingness to work hard to fix our broken system, and I'd be honored to lead the CMA in this very exciting work.
Thanks so much, Dr. McDonald. Dr. Oganyemi, if you could take a moment to introduce yourself.
Hello, everyone. Thank you for attending. Bonjour à tous. Merci pour votre
Hello,
temps.
everyone. Thank you for being here tonight.
While folks are here from all over the country, I'd like to acknowledge where I am currently. I'm grateful to be able to live and work on the traditional homeland of the Beothuk, the Innu First Nation, the Inuit of Nunatsiavut, the Inuit of Nunatuavut, the Halapu Mi'kmaq First Nation, and the Mi'apukek First Nation. My name is Bolu Oganyemi. I'm a medical dermatologist raised right here in St. John's, Newfoundland and Labrador. I'm an active father of 2 young girls. I'm also a MUN-Med graduate. I'm hoping to be the very first MUN-Med graduate to lead the Canadian Medical Association in its 158-year history. I work primarily in St. John's, and I have a regular traveling clinic in Labrador City, where I've been going for 8 years. I've been able to deliver care in St. John's, the rural community of Clarenville, as well as the Innu First Nation communities of Sheshatshiu and Natwashish in Labrador. I have a very diverse practice. My youngest patient was just 2 days old, and my oldest patients are over 100-year-old. I have a community practice. I share inpatient call at 3 hospitals. I'm an associate clinical professor of medicine and the inaugural assistant dean of social accountability at Memorial, and just the second person in this country to have such a role. Today's problems come from yesterday's decisions. We all know healthcare is in a crisis nationally, and the need for fresh perspectives and innovative and energetic leadership has never, ever been greater. I have 15 years of experience in health advocacy, and I've been on the leading edge of national healthcare for years. I completed a national fellowship in health systems improvement at Alberta School of Public Health. I was on the board of Canadian Doctors for Medicare for 3 years. I was involved with critiquing Bill 61 and pharmacare. I co-authored North America's very first climate change implementation plan. During the height of the pandemic, I was the only physician in this country to advise the government of Canada on who would receive the very first vaccine in Canada. I'm on the CMA Governance Committee, CMA Ambassador for 8 years, and I'm well positioned to be the national voice of physicians.
Thank you, Dr. Oganyemi. We'll now move into the question and answer period with our candidates. For the most part, the question and answers will come from the audience, so we encourage you once again to type your questions using the question and answer feature at the bottom of your screen. We'll also include questions received in advance of today's session. Thank you to everyone who submitted a question. You can upvote questions you see in the question and answer box if you'd like. We ask everyone to support a respectful, professional, and collaborative discussion. A note that questions that are discriminatory, defamatory, abusive, or offensive, or that violate privacy or confidentiality will not be addressed. As an exceptional measure, any participant who repeatedly submits inappropriate questions may be removed from the meeting. To give you time to post your questions, we'll start with a question that was shared with us ahead of tonight's event. This question will be asked by Newfoundland and Labrador's Medical Association representative. We've been working with the Newfoundland and Labrador Medical Association to promote this session and enable members to learn more about the candidates for President-elect. I'd like to welcome Dr. Steve Major, NLMA President, to come to the mic and to ask the first question this evening. A reminder that each candidate will have 2 minutes to answer. Dr. Major.
Hi, and thanks for the opportunity. The most common concern we've heard from members since the CMA's sale of MD management without prior consultation with physicians has been whether the CMA generally represents its members' interests. Some continue to feel that there is a disconnect between the organization and its members. If elected president, how will you work to address this perception and ensure that the CMA remains relevant and aligned with the interests of its membership. Thank you.
We'll invite Dr. Oganyemi to proceed with the first response.
There's clearly evidence of a major disconnect between CMA and members, and this can be seen through reduced engagement as well as reduced number of CMA members across this country. The CMA should assemble a formal engagement task force with representation from doctors all over the country, different practice types, rural and urban, different genders, and different stages in their career to learn about individual members' issues. The CMA should be intentional about seeking engagement, especially from physicians who are not members of the CMA. The CMA really needs to listen to doctors on the ground who understand not just our patients, but the needs of our communities and what can help us to deliver quality, timely care on a day-to-day basis. I think in particular, doctors from Quebec, doctors from the territories and smaller provinces do not always see themselves as part of the CMA. So it's important to have local engagement sessions and get local champions on board, folks that have influence. I think a specific example would be a robust longitudinal financial planning. This can be done by accountants and certified financial planners that are paid by the CMA. I think it would be particularly fitting because, as mentioned, it was the sale of MD management that led to so much distrust among members. I also think it's timely because we may have a change in our federal government coming up, and certainly there's recent legislation on capital gains inclusion rate that has concerned a lot of physicians and can have financial implications. This needs to start early. From the minute folks get their letter of acceptance to transitions in clerkship, residency, fellowship, early practice, folks taking parental leave and pregnancy leave, retired physicians, and estate planning. These are all areas that physicians and learners need access to one point in contact to discuss finances, taxation implications, and negotiate employment contract throughout our career. So this is something that the CMA can do to provide value to members that all members can benefit from.
Thank you, Dr. Oganyemi. Dr. McDonald.
The fast answer would be to say exactly what Bolu just said, because I totally agree with that. I do believe that there is a disconnect between the CMA and not only the membership, but physicians at large. And I think it's an absolute shame because the CMA is our national voice at all the important tables where decisions get made. So we need to have a more robust way of communicating between not only the membership, but physicians in general and the communities that they work in and the CMA. And it has to go back and forth. We have to hear what they have to say. They have to hear what we have to say. In regards to the actual decision-making process, let's face it, boards, and I've served on many, often make decisions that are somewhat at odds with what the general membership wants. And that's often because there's extra information that the board has at its fingertips that sways the decision one way or the other. I would urge everyone, regardless of their feeling about the decision about MD management, to not throw the baby out with the bathwater. It is incredibly important for our national group that speaks for us at all the important tables to be able to be strong enough and hear us well enough to be able to do that. I think there are many ways that we can create solutions to that type of problem. It probably should start in medical school. From the time people enter medical school, the CMA should be a strong focus and very active so that it grows with the student as they come into practice. Thanks.
Thank you, Dr. McDonald. And thank you, Dr. Major, for starting us off on the questions and answers tonight. We'll now turn to some pre-submitted questions that were shared with us in advance while waiting for some question and answers from the audience. Question number 1 was received from Dr. Madupe Denibayas, and it reads, "Thank you to both for applying for this position. In the last couple of years, the CMA is living through its commitments of EDIA and anti-racism. What have you done in in the past to address racism within the healthcare system? And if elected, what actions would you encourage CMA to take to make the healthcare system safer for marginalized populations? We'll start off with Dr. McDonald.
That's a great question. Years ago, probably almost 20 years ago, I started a course for my undergrad students in the palliative care course, and it was all about diverse populations. And it was designed to help medical students in the second year of medical school understand that dying and sickness is different. It's a different experience depending on your culture, your religion, where you live, all sorts of different things. And I think I was a bit of a leader to do that because there was no other course 20 years ago on that. I've worked very hard within my particular field to encourage my colleagues and the unit that I work on to be far more inclusive than we used to be. And I think that has had a very positive result. I recognize that for many people, healthcare is a scary and dangerous place, and not just because of people from different cultures who are not used to what we do, but people who have been marginalized for a variety of reasons, and sometimes even because of their illness. And we all know that patients with mental illness particularly struggle with this. I think that pushing this agenda to the forefront and reminding people on a constant basis is absolutely key. You don't know what you don't know. And I think if you asked most clinicians, they would say, oh yes, I'm very inclusive and I'm very knowledgeable. But the fact is that we all have inherent biases. We all live the way we were raised to live. And it's only by putting this at forefront that we will learn to do something better.
Thank you, Dr. McDonald. Dr. Oganyemi.
I have a very, very extensive history of anti-racism. I've spoken on CBC, Globe and Mail. I've been published in every major newspaper in this country in the areas of anti-racism health, including CBC, Globe and Mail, and the Toronto Star. I've done anti-racism course from Western University as well as Cornell University. I've been part of the EDI committee of the Canadian Dermatology Association, Memorial University. I'm an advisor for Black Physicians of Canada. After George Floyd, I took the initiative to create 4 individual lectures for faculty members at Memorial, resident physicians, graduate students, and medical students, and I personalized them. I've mentored many marginalized women in dermatology and in health in general. I've delivered over 30 lectures to university, professional communities, the Canadian Medical Association, the College of Physicians and Surgeons of Canada, medical students, dentistry students in University of Toronto, McGill University, and Memorial University of Newfoundland. I'm largely seen as kind of the go-to person when it comes to anti-racism and the intersection of health and racism, not just within Memorial in Newfoundland, but I have a national profile as well. I'm certainly committed to this, and I have the lived experience. I want to create, a society that's better for my 2 daughters than the society we are in today. And certainly, health as an institution does have an important role to play, whether it's anti-Black racism, anti-Indigenous racism, Islamophobia, or anti-Semitism in medicine. And the intersectionality of a lot of folks. Our institution in healthcare has a lot to do, and that relies on our work as individuals. So I've been living and breathing this for my entire life.
Thank you, Dr. Oganyemi. I'm going to turn to some questions that we picked up in previous sessions over at the CMA. One of them has centered around health human resources, and Newfoundland and Labrador obviously is not isolated from the same sorts of challenges we're seeing across the country. So maybe we'll start off with you, Dr. Oganyemi. How do you envision addressing the health human resource shortages that are likely to get worse over the next 3 to 5 years?
We really need a robust health human resources plan that, as you mentioned, not just to meet the needs now, but in the future. So there are a number of things. One is to retain. The primary goal is to retain physicians and other health workers that we have. We know that it's not just a national marketplace; it's international competition. We have very trained physicians and other health professionals. So we need to retain them by learning what keeps them there, what will keep them, whether it's an urban setting or a rural setting. We also need to recruit. We need to recruit folks from different parts of the world with folks with different skills that we need not just now and into the future. And we need to be flexible. Sometimes the package that we create is not exactly what they'll need, and it's not just recruiting to get folks here. We need to keep them in the communities and really integrate folks, especially folks with different cultures. And as you mentioned, Newfoundland and Labrador, as someone that moved here when I was 3, can have a lot of cultural differences from the rest of this country. So we need to make sure that they're properly integrated. I've given a talk on the importance of cultural integration for recruiting international physicians, and I've learned a lot, about this. We also need to train. The long-term plan is we need to train a homegrown workforce, and so we need to train folks not just in health, in physicians, nurses, and all allied healthcare workers. We also need to train folks so they're used to working in a team-based care environment. We need to be nimble, and we need to listen to the people that we're trying to recruit. What's important to them? What will keep them there? And why have some folks left? So exit interviews are important to see why folks leave, where they're leaving, and what we can do better.
Thank you, Dr. Okanyemi. Dr. McDonald.
Thank you. A workforce plan is something that I was on the news quite frequently about when I was president, because it is a common problem across Canada that we just don't have a clear plan of how many physicians we need, where they should they be able to move, how should this look, and how many allied health practitioners should be integrated with physicians, and what should that look like. And it's still, years later, it still hasn't happened. And it seems to me such a basic step in creating the workforce that we want. In talking to a lot of clinicians across Canada, some who work in very remote places, others who work in really urban spots, that doesn't sound like there's one perfect place. There's concerns and difficulties everywhere you go. And I think I agree entirely with Bolu about talking to the people who work in those places and looking at what makes you happy and what makes you frustrated. And I'll tell you, it's not only money. Everybody focuses on how much money, but if you're not happy where you live, if you can't make friends in your community, if you're on call all the time, no amount of money is going to fix that. So looking at all those kinds of things, I agree absolutely with retaining. We have a lot of physicians, but we can't keep them. Why can't we keep them? That's a big question. Why do medical students, when they come in, decide not to do primary care and want to look at other things, and why are they not interested in rural? That's something we really need to be paying attention to. And then encouraging, as you said, encouraging our own to stay here because they already know the environment.
Thank you, Dr. McDonald. The next question I think is a pretty pertinent one, especially for myself. I live in northern Alberta, and obviously there's been fires up here over the last few summers. What will you do to address the lack of education in our medical schools of climate change? What will you do to support developing initiatives meant to sustain and improve planetary health, thereby decreasing climate-related effects on health and the environment? And I'll add on just a small little addition to that. How will you prepare physicians and learners to understand the impacts that climate change actually has on clinical practice? We'll start off with Dr. McDonald.
Thank you. Climate change was not even on my radar when I went into medical school, and I I don't know how much climate change is being taught in medical schools, but I suspect it's not very much. And we know from evidence that there's a huge impact on health because of climate change. That if it's too hot, if crops don't grow, if there's more insects that are passing germs, et cetera, et cetera. And I think it's absolutely imperative that people understand this. Until I did a little bit of research, I didn't understand it either. I didn't realize that a quarter of our healthcare facilities are actually built on a floodplain. I mean, it boggles my mind. So I think that needs to be, there's two parts to this. One, I think that we have to educate physicians, and we have to educate physicians not only about the impact on health by climate change and what kinds of things they can expect to see, and prepare the system for those potential problems. But we also have to recognize that healthcare itself is causing climate change because we have a huge carbon footprint. So how can we, as healthcare providers, look at our system really carefully and reduce our own carbon footprint by making our hospitals healthier and more environmentally friendly, etc. And then I think there's also the educational in the medical school, and I would be strongly advocating for the medical school to have a very robust section of education on this, because I think it's absolutely crucial. And we all recognize things are only going to get worse with climate change, so we have to be prepared. Thanks. I can't see a timer, so I don't know if my time's gone.
Thanks, Dr. McDonald. Dr. Ogunyemi.
Great. So I was the inaugural Assistant Dean of Social Accountability at Memorial University. My portfolio included Indigenous health, global health, and community health. Upon finishing my role, we advocated for planetary health to be included as the next pillar. BC is really doing a lot of pioneering work in this area. I got to speak with a lot of leaders in climate change as during my national fellowship in health systems improvement, where I co-authored the very first climate change resiliency and leadership program for healthcare leaders. So we're currently funded by the BC Ministry of Health, because of course many forest fires in interior health, and that has affected Newfoundland and Labrador, and actually affected the clinic I was supposed to do in Labrador City. There are certainly many things we can do. First, we should realize that first do no harm begins with the world and with climate change and the environment. So we must minimize our carbon footprint. 5% of all emissions in this country are from healthcare, and that's actually more than the aviation industry. There are many things that we can do. So choosing wisely is something that many medical students, learners will know about the cost. Do we really need the test? We should also be thinking, what's the carbon footprint of this test? Can I do another test? This is something you can teach very early on in medical school. And there's many other things that we can do institution-wise. We need places for bikes to encourage that, EV chargers, infrastructure. Whenever we're creating new healthcare institutions, we must make them efficient, or even have a new net zero building. Some practical things are reducing desflurane in terms of anesthetics and choosing other options. Those are some of the things that we're discussing as a member of CAPE NL.
All right. Thank you, Dr. Ogunyemi. Question 4 is asked by Tracy Bridger. Many Canadians are concerned that we may be moving away from universal health care and towards increased privatization, which could create inequities in access to care. What are your thoughts on these concerns, and how would you, as CMA president, advocate to ensure our healthcare systems remain universal and accessible to all? We'll start off with Dr. Ogunyemi.
You know what? I've been on the board for Canadian Doctors of Medicare for 3 years, and I had the privilege and opportunity to critique Bill 61, National Pharmacare, which of course was monumental in the history of this country. So I believe that we need to innovate our public healthcare system, right? So we know that there's evidence of things that work. Central triage works. There's evidence that having a physician in triage that can kind of move people faster through the emergency room waits can work. We need to leverage virtual care in certain settings. So we can innovate the public system, because it is true, the public system is currently not meeting the demands of Canadians. Privatization is not the answer, partially because it actually goes back to the human health resources issue, right? We're currently in a situation where you're kind of robbing Peter to pay Paul, because if we are to put folks to work in the private system, where are they going to come from? We know we have a health human resources challenge, so they would only come from the public system, and therefore increase waits in the public system, and therefore worsen access to care for folks who can't afford it. So I do think that we really need to be creative in innovating the public healthcare system and protecting access to care. So that's in terms of private funding. We also need to consider private delivery. Private delivery of care is going on and actually has many benefits. Care outside of hospitals and healthcare institutions can be efficient. We do need to keep an eye on kind of upselling that can happen. I mean, certainly a lot of my work is in a private clinic outside of the hospital. So, I know from personal experience that there are benefits of privately delivered but publicly funded healthcare.
Thank you, Dr. Oganyemi. Dr. McDonald.
Thank you. Having worked with marginalized communities at the dying for 30 years, I am a tremendous supporter of the public system. And I recognize that the system that we have has included private as well. Many people don't have coverage for their pharmaceuticals, and some of my patients haven't been able to pay for their opioid medications, for example. I think it's the universality of healthcare has always been one of the things that I am a tremendous believer in. Growing up with no money, there's lots of things I wouldn't have been able to access if it hadn't been for a healthcare system that allowed it. And so I truly believe that we need to encourage our national universal healthcare system to be as robust as possible, and only private when absolutely necessary, or it fills a niche that cannot be filled by public dollars. And that means that we have to be really smart about where we spend money, because there's a limited pot. It's not unlimited. It's not like we have billions and billions and billions that we can throw at this. We have to look really carefully. So we have to look at evidence base. What works? What doesn't work? Who should get this? And how do we prioritize those kinds of things? We need to be spending our money really wisely when it comes to the clinicians within the healthcare system. So who should do this job? And can we use somebody who costs a little bit less to do a very similar job and leave the more expensive jobs to somebody else? I think it's complicated, but I believe in it.
Thank you, Dr. McDonald. We have our question number 5 from CMA staff. This was asked by Jeff Power. In the context of the CMA's commitment to social accountability, how do you envision the role of the association in addressing inequities within the healthcare system, particularly in underserved or marginalized communities? Specifically, what policies or initiatives would you champion to ensure healthcare access and equity align with the evolving needs of Canadian society? We'll start with Dr. McDonald.
Well, I think, Jeff, if you look at the Impact 2040, a lot of these things are covered as major goals of how that's going to happen. The details, I don't have the actual details of how we're going to do it, but it is an absolute key priority that we are able to champion and ensure healthcare access and equity across the entire society, and in particular looking at groups that have historically not had adequate access. For example, our Indigenous populations have constantly been marginalized and are still marginalized. New Canadians, for example, are often marginalized in our system. The aged, marginalized. My population of palliative patients, marginalized. I think that by embracing the Impact 2040 and really putting a lot of effort into working through the details of how this is going to work with an emphasis on those patient populations will only do us some good, and particularly those patient populations. Remember, there's an old adage of a picture of three kids looking over a fence, and they're all looking over, but each one is standing on a different height stool. That's how I see medical care, that some people just need more than others because it's not equal. I'm a tremendous proponent in my practice, my clinical practice, and I think that would spill in very strongly into leadership in this with the CMA. Thanks.
Thank you, Dr. McDonald. Dr. Oganyemi.
Thanks. So, well, I have some answers because I've been doing it. So I traveled to fly-in communities in Labrador to manage pediatric eczema and cutaneous infection outbreak, which has been going on in many Indigenous communities across Canada. So it's important to meet people where they are, to work in their communities, to listen to their problems in person. Many folks appreciate that. Indigenous folks certainly appreciated me going to the land. Not only are people comfortable in their settings with their loved ones, it saves time, effort, and money. They don't have to travel to the big city in St. John's. So it's important to promote this type of thing because it's easier to move one physician to a remote part of the country than to move, the dozens and dozens of patients that I saw that I can, and so that's in one area, but I regularly do traveling clinics. So rural populations, remote populations, Indigenous populations, we need to meet them where they are. We need cultural competent care because everyone, regardless of your background, should be able to have cultural competency, cultural humility. So that's very important. It's important to train people where you want to practice. So I advocated for a distributed medical education in Parliament many years ago, and we still need to do more of this. So we need rural streams, both in medical school and in residency for many different programs. So folks are used to delivering care in these communities. And we need to think creatively. One example in Saskatchewan, they're taking it's folks from rural, remote areas of Saskatchewan, bringing them to Saskatoon, teaching them how to use an ultrasound probe. They go back to their home communities, do the ultrasound in the rural community, and it gets read in Saskatoon. Practical example. That's what we need to implement.
Thank you, Dr. Oganyemi. Question number 6. The CMA president regularly communicates with physicians, medical learners, political decision makers, and the public. Please comment on your skills experience with communicating with these diverse groups of people, and how will you use your communication skills to best represent physicians? Dr. Oganyemi, if you can start us off.
Right. So I agree. A big part of the role rather is to be a spokesperson. I've developed communication skills through time, both written and oral communication skills. I published in the New York Times, and as I mentioned, in most national journals. And I think it's important to be able to deal with different people. So not only do I give lectures, I speak to professional associations, I speak to folks in the community. So while I do teaching in hospitals, I give community care lectures in different settings, in community settings, in a healing lodge when I was in Labrador. So I think it's important to connect with different folks and use different communication skills. I've given a TEDx talk. I think it's important to be able to kind of leverage different skills in communications. I've fortunately been awarded the Cultural Educator of the Year by the Association for New Canadians for a lot of my communication. So I do think that kind of one has to adapt communication style to who they're talking about. Sometimes, if it's policy based, sometimes keeping it, keeping it simple. So, fortunately, I have been able to communicate in many different ways with different audiences. So I know that I have the skills to be the national voice of physicians to communicate in this way. I've served on 5 board of directors and have been very vocal in advocating for many different groups, whether it's provincially or nationally. I actually served as communications director of resident doctors of British Columbia and chair of the communications committee, and have helped some folks in finding their voice, right, and running our resident awareness week. So I think whether it's speaking on behalf of medical learners, marginalized populations, the community at large, or our great profession, I have the communication skills.
Thank you, Dr. Oganyemi. Dr. McDonald.
Thank you. I work in a field that is 90% communication. And so I've had many, many, many years of experience dealing with a variety of different patients and clinical colleagues, families, all of whom are generally pretty distressed. Like Bolo, I have a number of publications, including a textbook. And so written communication is something that comes very easily to me. I also write novels in my spare time, so that's one of the things I quite enjoy. I've done a lot of public speaking. If you turned on the news during the year I was president of the NLMA, you would have seen me. And I think the effectiveness of that communication was borne out by the fact that we, after 4 years, did get our contract, and our Minister of Health did step down. I am very keen to use very plain language. I like to make sure that everybody can understand. I specifically use the tools of storytelling often to get my point across and to ensure that people understand. And I also often use humor as well. I've spoken to the Senate about medical aid in dying, and I had to speak to the membership about medical aid in dying when I was president, and our membership was in fact divided in half, and there was an attempt to split off and break the Canadian Society in two. And it was clear, warm, empathetic communication that allowed people to feel strong and empowered that brought that society back together. So that was a strong point on my part.
Thank you, Dr. McDonald. Next question. How do you think the Canadian Medical Association can support learners, so medical students and residents, working in toxic clinical environments, given their limited ability to advocate for themselves because of power differentials? We'll start off with Dr. McDonald.
Thank you. I think most of us walked through our medical training and at some point experienced something toxic. And I think we all felt pretty perhaps desperate or frightened or powerless to do something about it. The CMA has a very strong point within Impact 2040, which I keep going back to because it really does drive everything that we'll be doing, about a safe environment and a safe culture within medicine to practice. And I would hope that through that, we can really advocate for students and residents, that we could perhaps develop a safe space for them to communicate to us, and that we could advocate on their behalf and teach them the best ways and give them tools to stand up for themselves. I think getting into the medical schools and supporting the medical schools, certainly our medical school here at Memorial has done some good work in regards to anti-bullying and has made some tremendous strides. And I think that can be that can be pushed into the clinical workplace as well. It's not just faculty that need to know that, it's everybody. And I think that we can really advocate for a safe and supportive environment. Nobody should feel badly because of their supervisor treating them in a certain way, or an allied health person treating them in a certain way. We're all deserving of respect, and I think when you give respect, you should get some back. So there.
Thank you, Dr. McDonald. Dr. Oganyemi.
I had the opportunity to serve as a founding faculty member of the Royal College Anti-Black Racism Accreditation Working Group. We work closely with the Royal College Anti-Indigenous Racism Accreditation Working Group to develop a number of policies that would protect students and residents. So we developed key requirements for safe and effective reporting mechanisms to address racism and other forms of depression in the workplace as medical learners. We also advocated for mandatory anti-oppression training for anyone involved in teaching residents or learners. Personally, I created all of the professionalism modules at Memorial University that specifically relate to anti-racism in the workplace, and that applies both to medical students and learners in particular, but also to faculty members as well. So I created, of course, the module and the rubric, and revised the rest of the professionalism module because I'm seen as having experience in this area. So I do think it's very important that we protect folks. There was recent issues with the tendering of CARMS and whether the AFMC would own it or whether it would continue to be shared with the CFMS, RDoC, and other members. I have been fortunate to be speaking with the president and other leadership of Resident Doctors of Canada, as well as leadership of medical students, in order to advise against this. I actually wrote a letter to Mark Holland, our federal minister of health, and AFMC about the importance to share the match to ensure that medical students and residents are prioritized and their needs are heard. So from both from a professional, an educational, and a policy perspective, I've been very active and plan to continue to be active to protect medical learners.
Thank you, Dr. Oganyemi. We'll now ask on each of the candidates to provide some parting words. We'll start off with Dr. Susan McDonald and follow with Dr. Bolu Oganyemi. And just a reminder, you'll have 2 minutes. Go ahead, Dr. McDonald.
Thank you, Dr. Lafontaine, the technical crew of the CMA, Dr. Oganyemi, and all the participants who took time out of their busy schedules to join us tonight. Healthcare is at an all-time low. All of us struggle in an overwhelmed system. Every physician I know wants to care for the patients the best way they know how, with the minimum of bureaucratic interference. And every physician wants to feel respected and valued for their work. I'm an optimist. There's always a silver lining. And I think it's the incredible strength in the physicians of this country. Physicians innovate and rise to any challenge. COVID was a perfect example of that. We must harness that strength and innovation to move forward, even when we're tired, frustrated, and feel stuck. I feel that the CMA has a workable prescription in Impact 2040, but it's going to take a lot of work. There are serious changes needed ahead. The healthcare system we work in was designed decades ago, when things were very different. I believe we must embrace change. That means working in teams, reimagining our roles, embracing elements of AI that work for us, among many other ideas. All of us want the best for our patients. And in order to get that, we need a healthy, resilient physician workforce. And in order to achieve that, we need to try innovations, be creative, take chances on creating a new healthcare system. I strongly believe we need to be at the tables where decisions that affect us are made with a persuasive and direct voice. Remember, if you're not at the table, you're on the menu. We need strong, experienced leadership that is committed in creating the best environment for our patients and ourselves. And I'm offering myself as that leader. Thank you.
Thank you, Dr. McDonald. Dr. Oganyemi.
We cannot accept this as a status quo. We cannot accept our current state of healthcare. Whether it's emergency wait times for up to 22 hours, 20% of Canadians not being attached to a family doctor, surgeries canceled over and over again due to staffing shortages. We can't get accustomed to delays in pediatric care, eliminating their chances at early intervention for optimum development. Siloed and fragmented health systems and medical records must not be normalized. I will never accept rural, remote, and Indigenous patients receiving substandard care. We must change the fact that doctors in many settings are unwell, suffer from reduced autonomy in health systems, and health systems that can't possibly function without them. We need a paradigm shift. We need real change. I've been a change maker my entire life. My vision is of a future-focused health resources plan. We need to deliver on CMA's plan for reconciliation, improving Indigenous health outcomes. My vision includes strengthening primary care. We know primary care leads to reduced health inequities, reduced long-term costs, and improved overall health outcomes. We need team-based care and everyone to work at the top of their scope of practice. In listening face-to-face to doctors in Carbonear, Clarenville, Burin, Gander, Grand Falls, and Labrador City, it was abundantly clear that inequities in rural healthcare are massive and really need to be tackled, whether it's capital investment in infrastructure, more robust transport, and focus on flexible recruitment and retention. We must attend to rural care. We need physician-informed health systems. This can reduce administrative burden. My vision includes interoperable health systems and adopting AI. If elected as the president of the Canadian Medical Association, I will deliver on improving health system for all, accountability to health outcomes, robust health workforce, stronger communities, and united profession. Please join me in my historic campaign.
Thanks to both of the candidates for their obvious passion and commitment to rebuilding the health workforce, health system, and the health of our patients. Thanks to all of you for taking time to join us. Before moving on to what's next, we have 2 short polls to tell us what you thought of today's session. Your feedback will be important to ensure we hit the mark with sessions like these, and those polls should be coming up on your screen right now. We'll send out a more fulsome evaluation by email as well. For the first poll, we'd ask you to rank participating in the Meet the Candidates session on whether or not it was a good use of your time. And we'll give you a moment just to fill that out. The second poll will look at whether or not you feel more connected to the work of the CMA as the result of this Meet the Candidate session. So now what's next? Tomorrow, November 20th, an invitation to vote will be emailed to CMA members in Newfoundland and Labrador, whose membership was active as of November 8th. The election period will open tomorrow, November 20th, at 8 a.m. Eastern Time, 9:30 a.m. Newfoundland time, and closes at 4:30 p.m. Eastern Time and 6 p.m. Newfoundland time on December 4th, with election results declared by December 6th. If you're unsure of your membership status, we encourage you to email membership@cma.ca. Once again, membership@cma.ca. The elected nominee will be put forward for approval by CMA General Counsel at the annual general meeting on Saturday, May 31st, 2025. As a special note, we are seeking to fill 2025 vacancies for positions on the CMA Board of Directors, as well as several committees. For details, please click on the link in the chat. The deadline to apply is December 31st. Thanks again to everyone for joining us. Merci and Chi Miigwech.